Hello, everyone. This is Dr. Wang Zhifei from Zhejiang Provincial People's Hospital in Hangzhou, China. My topic today is the validity of a 3D printed dry model in laparoscopic anti-reflux surgery training. I have nothing to disclose. The reason I chose this study is because for most Chinese surgeons, they're not familiar with laparoscopic anti-reflux surgery. As a matter of fact, this is only written into the textbook of medical college students 2 years ago. And according to literature, a learning curve of at least 20 cases is needed versus the fact that the lack exposure for most Chinese hospitals. And minimally invasive surgery training as a fellow is not available in China until recently, but laparoscopic anti-reflux surgery is not included. However, the emergence of 3D printing technique enabled efficient production of realistic biomaterials and anatomically accurate models, which have been demonstrated the very advantage for minimally invasive surgery training. But after designing a 3D printed model for surgery training like anti-reflux, we do have to firstly validate its validity before it's further applied. Also is from the literature said the failure of cross closure and the malformation of the wrap are the main reasons of failure for anti-reflux procedures. That's the reason we address the two parts mainly in this model for our training. And this is actually an extent for our previous study for the 3D printed dry model training. For example, we did such model for laparoscopic and robotic pancreatitis, bariatric surgery, gastrogenostomy, etc. So this study is to evaluate the validity of 3D printed dry models for LAS in reference of their phase, content, construct, concurrent, and productive validity by OSATs. So this is a box one, the definition of the validity for each part. A 3D printed dry model was designed to simulate LAS to help surgeons to acquire basic skills and the special situational processing. Participants were prospectively recruited into 3 groups, with 6 experts into Group X and 20 novices into groups A and B, depending on their surgical experience. The performance of models assessed by 2 judges using a global assessment tool. So this is the assessment tool we call SETS. Contains these assessment procedure and the general technical assessment. This is originally designed for the robotic surgery, but we modify it into our surgery training. So we correct the first item, change the first item into the designing of the ports, trocar's position with the total score of 24. So this is model. This is a training box, and that's for pulse instrument, the light to and the models, and this pumping the red color water, simulate bleeding, and everything recorded. This is actually at my office. So all the trainees are asked to come to my office and do the training. Now this is all the procedures about the esophagus. This is the hiatus and simulated hiatal hernia. We close the hiatus right here, and we use a surgical cap as the mesh for fixation as needed, of the mesh as needed, and also the bleeding. This is the embedded silicone gauze catheter, soft one, embedded into a silicone pad, and this is the spleen right here and the stomach. So this is connected to a pump, pumping the red color water, simulating bleeding. We do have to control with one forceps and do the one hand suture of the bleeding. And also this is a stake put into the esophagus, simulating the bougie. And we do the fungification. This is Zhifei maneuver. And we make the short and floppy fungification 360 degree. Also, we fix the wrap here. So this is completion of the surgery training. So following the model training, the participants were asked to evaluate the phase and content validity model, and they were assessed with an overall rating using 5-point Laparoscopic scale for overall impression, realism, ethics, and usability and handling. So for constructive validation, we do see this is from group X, A, and B. So overall, the expert completed the dry lab task more efficiently than the novice surgeons in group A and B as expected. And there are a great difference between them. And also for the during the bleeding scenario, participants change in heart rate and time for hemostasis. There was a significant difference between each groups also. So for all the participants complete the questionnaire, and overall impression, the model was highly evaluated in all respects. And group X performed better than group A, with A better than B. And then we deduced that there's a linear correlation of time or set score between performance model and the real patients. So this is the the concurrent and the predictivity validity. So we do see the correlation of time between the models and the practice time, and also the correlation of sets score between model and reality. So to conclude, 3D printed dry lab model simulating the anti-reflux surgery can provide safe and valid training for laparoscopic anti-reflux surgery, bridging the gap in early laparoscopic nasal fungification learning. The training model is rated favorably for anatomic realism and generally accepted as a valuable tool for advancing critical laparoscopic fungification skills by participating and assessing surgeons. We do have quite a few limitations, like not all the steps in the operation is simulated with this model, and we fail to observe the effect of the fungification as conventionally observed with the endoscope in the OR. We can make a teeny tiny hole in the future to observe the wall, the wrap, hopefully. To take home message, anti-reflux surgery can be simulated partially on a 3D printed model, and the training model can be validated by all sets. Thank you.